I would like to thank the scientific committee for this invitation to give a lecture about the sonographic assessment of cervical lymph nodes and how to recognize the ultrasound characteristics of benign and malignant lymph nodes. So thyroid cancer recurrences are diagnosed by neck ultrasound in 95% of the cases. Most these recurrences are metastatic lymph node in 75% of the cases. Half of them are detected in the 3-4 levels and half of them in the 6 levels. Of course, recurrences in levels 5 and 2 are possible, but less frequent. Recurrences are diagnosed in the thyroid bed in 20% of the cases, and subcutaneous muscle tissue recurrences can be diagnosed in 5% of the cases. The assessment of neck lymph nodes include 8 ultrasound criteria, which are the size of the lymph node, the shape, with the evaluation of the long axis over short axis ratio, the echogenicity of the lymph node, the presence of a normal central hyperechoic hilum, the presence of cystic areas, cystic appearance, the presence or not of hyperechoic punctuations, the description of the distribution of the vascularization, and the presence of a thyroid-like tissue appearance. According to the European Thyroid Association guidelines published in the European Thyroid Journal in 2013, lymph nodes can be classified into 3 categories. The first category is the normal lymph node category, corresponding to lymph nodes with a normal central hyperechoic hilum with an ovoid shape and no or central vascularization. On the opposite, there are the suspicious for malignancy categories. There is the suspicious for malignancy category, which includes lymph nodes having at least one of these signs: microcalcifications, cystic areas, thyroid-like tissue appearance, or peripheral or diffuse increased vascularization. And in between, there is the indeterminate lymph node category. Those indeterminate lymph nodes have no suspicious signs, meaning no microcalcifications, no cystic areas, no thyroid-like tissue appearance, no peripheral or diffuse increased vascularization. Indeterminate lymph nodes have no central hyperechoic hilum and at least one of the following signs: a round shape, in other words, an increased short axis, and or an increased central vascularization. So lymph nodes, especially suspicious and indeterminate lymph nodes, can be drawn on a diagram indicating the levels of the lymph node with a color code. And for example, suspicious lymph node in red, indeterminate lymph nodes in yellow, and benign lymph node in green. A benign lymph node have a normal central hyperechoic hilum with a long flat aspect, in other words, with a long axis to a short axis ratio above 2, neither with microcalcifications nor cystization, and a well central vascularized hilum. In these cases, of course, there is no indication for ultrasound fine needle aspiration biopsy. So here you have a typical example of a benign flat lymph node with a normal flat hyperechoic hilum. Here another example of a typical benign lymph node with presenting a long axis to short axis ratio above 2 and a central hyperechoic hilum. And here you can see 2 examples of a normal central vascularized hilum. So what do you think about this lymph node? Is it benign? So yes, it is a benign lymph node. The hyperechoic ileum is quite thicker than usual, but you can see the flat form of the lymph node with the usual hypoechogenicity at the periphery of the ileum. Indeterminate lymph nodes have no visible hyperechoic ileum and at least one of the following signs: a round shape, in other words, an increased short axis above 5 to 7 millimeters, and or an increased central vascularization. In those cases, ultrasound needle aspiration biopsy may be discussed, taking into account the stage of the initial thyroid cancer, the histology, having in mind that metastatic lymph nodes are less frequent in follicular thyroid cancer compared to papillary thyroid cancer. So the indication of needle aspiration biopsy may be discussed according to the size of the lymph node. If the lymph node is very small, under 1 centimeter, probably you will not decide net surgery, so needle aspiration biopsy is not very useful. And you can take into account the plasma TG level concentration. So here are 2 examples of indeterminate lymph nodes without any visible ileum and an increased short axis more than 5 to 7 millimeter, and here a typical round shape. Suspicious for malignancy lymph nodes have at least one of the following signs: either microcalcifications or cystic areas, or thyroid-like tissue appearance, or peripheral or diffuse increased vascularization. In this case, ultrasound needle aspiration biopsy is necessary when, must be discussed when the lymph node measures more than 1 centimeter. And if you decide to perform a needle aspiration biopsy, perform systematically an in situ assessment of TG or CT level. So here are 2 examples of very suspicious lymph node with multiple microcalcification, as you can see here. Here is a very suspicious lymph node with a typical thyroid-like tissue appearance. Just one slide about the anatomy of lymph nodes. Physiologically, a lymph node has a normal hilar central vascularization, as you can see here in this picture. And you have here the corresponding ultrasound aspect with a normal central hilar vascularization. Lymph node metastasis presents peripheral vascularization pattern at initial stages to multiple vessels branching irregularly, chaotically at late stages. And you have here the corresponding ultrasound aspect, here with a peripheral vascularization, and here an irregular, chaotic vascularization. So these are 3 examples of very suspicious lymph nodes, all presenting cystic areas. Assessment of thyroid bed should include the description of the presence of remnants and their size, and the description of any potentially abnormal lesions, including the size of the lesion in the 3 dimensions, the shape of the lesion, the borders, the echogenicity, and the description of the vascularization of the lesion. Note that the assessment of the thyroid bed, including central compartment and level 6, is difficult during the first 3 postoperative months following thyroid surgery. And note also that the assessment of the thyroid bed should take into account if the patient was given radioiodine. Because if the patient was given 100 millicurie radioiodine, you are not supposed to see remnants a few months after radioiodine treatment. Normal thyroid bed can be described as an hyperechoic area between the trachea and the carotid, with internalization of the carotid and jugular axis. And if you see a thyroid remnant, it should be described as a regular and homogeneous tissue. There is one pitfall. It is the pre-existing thyroiditis. And in this case, remnants could be quite heterogeneous, hypoechoic, and sometimes with hypervascularization. So in this case, you have to look at the histological report and search for histological thyroiditis. So here are two examples of a normal thyroid bed. So you can see here a hyperechoic area between the trachea and the carotid with internalization of the carotid and jugular axis. And here is a typical example of a normal remnant, which appears as a regular and homogeneous tissue without any hypervascularization. The suspicious thyroid bed lesions appear as a lesion with ovoid shape in the longitudinal plane, but taller than wide in the transversal plane. Hypoechoic lesions, sometimes with microcalcifications and or cystic components, irregular borders, and or increased vascularization. So here are two typical examples of very suspicious thyroid bed lesions. You can see here a cystic component, and here typical, the taller than wide shape in the transversal plane. So here are four examples of very suspicious thyroid bed lesions. You can see here the typical taller than wide shape in the transversal plane. All these lesions are hypoechoic, especially this one and this one, with irregular borders, ovoid shape in the longitudinal plate, but taller than wide in the transversal plane, and sometimes with increased vascularization. Recurrences in subcutaneous tissues and or muscles can appear as solid tissue zones with irregular borders, sometimes vascularized using paradoppler. And you can see here a suspicious lesion in neck bottom. The interpretation of neck ultrasound results must take into account the location of the initial thyroid cancer, right, left, bilateral, because contralateral metastatic lymph nodes are possible, but far less frequent than homolateral metastatic lymph nodes. The histological type of the thyroid cancer, was it a follicular thyroid cancer or papillary thyroid cancer? Because metastatic lymph nodes are much more frequent for papillary thyroid cancers compared to follicular thyroid cancers. It is interesting if you have this information to take into account the thyroglobulin or the calcitonin plasma concentration, because lymph node metastases are unusual if thyroglobulin under LT4 is undetectable. And it is very useful to have an idea of the estimated risk of structural disease recurrence. Is it low, meaning that your patient has a history of small intrathyroidal thyroid cancer without lymph node involvement? Is it intermediate, meaning that your patient has a history of thyroid cancer with minimal extrathyroidal extension and or a tumor measuring more than 40 millimeters, and or with minimal lymph node involvement only in the central compartment N1A with less than 5 metastatic lymph nodes measuring between 2 to 10 millimeters? Or is it a patient with a high risk of structural disease recurrence, meaning a patient with a history of locally highly invasive thyroid cancer with massive lymph node involvement? And you must be specific for low to intermediate thyroid cancers, meaning describe mainly suspicious lymph nodes and forget intermediate lymph nodes. And you can be sensitive for intermediate to high-risk thyroid cancers and describe, of course, suspicious, but also indeterminate lymph nodes. So now let's practice. So this is a suspicious lymph node with cystic areas. So what do you think now about this lymph node? So you can describe it as an indeterminate lymph node without any hilum and an increased short axis above 5 millimeters. And what do you think about this lymph node? Is it benign, indeterminate, suspicious? How you may describe it? So you can see here a quite large, thick hilum with a round shape. And you must be cautious with this aspect because sometimes you may have early metastatic deposits in this large, thick hilum. So you have to take into account the context, the history of the thyroid cancer. Was it a low risk, an indeterminate, or high risk? How is the TG level of plasmatic concentration, and so on. So what do you think about this lesion? Is it normal, benign? Is it suspicious? How do you describe it? So actually, this lesion was a postoperative lymphocyte. Lymphocytes are lesions with spontaneous favorable evolution, meaning a decrease in size, sometimes in few months. It is observed typically during the 3 postoperative months. The main differential diagnosis is a cystic metastatic lymph node. So you have to analyze the context. Is there a recent neck surgery? Is there a history of low, high-risk thyroid cancer? And you can also watch and see the evolution of this lesion. If it decreases in size in few months, you have the diagnosis of postoperative lymphocyte. So what do you think about this lesion? Benign, indeterminate, suspicious? How can you describe the lesion? The echogenicity? Is there any microcalcification, cystization, the shape? How you describe it? So actually, this was a suspicious lesion in the thyroid bed, which corresponds to a recurrence in the thyroid bed from a HER2 cell, in other words, oncocytic thyroid carcinoma. And you can describe this lesion as a hypoechoic lesion with a taller than wide shape in the transversal plane. So what do you think about this lesion? So this was a suspicious, very suspicious lymph node with a round shape, diffused increased vascularization, thyroid-like tissue appearance, very probably metastatic. So now, what do you think about this lesion? Suspicious, indeterminate, benign, your ultrasound description. So you can describe it as an indeterminate lymph node This lesion has no visible hyperechoic ileum and an increased 5 mm short axis. And on needle aspiration biopsy, actually, it was a metastatic lymph node of a diffuse sclerosing variant of papillary thyroid cancer. So now, what do you think about this lesion? So you can describe it as a very suspicious lymph node with a typical thyroid-like tissue appearance and peripheral vascularization, and on needle aspiration biopsy, it was a metastatic lymph node. On the left, 8 cm poorly differentiated Hurtl cell oncocytic thyroid cancer. So now it was the same patient, and there is also this other lymph node. How would you describe it? So you can describe it as an indeterminate lymph node with a very thick ileum occupying almost the entire lymph node. And on needle aspiration biopsy, it was a benign lymph node. So what do you think about this lymph node? So of course, it is a very suspicious lymph node with cystization, important cystization. And on needle aspiration biopsy, it was a metastatic lymph node of a papillary thyroid cancer. So what do you think about this lymph node, this lesion? So you can describe it as an indeterminate lymph node without any ileum and a 5 mm short axis. And on needle aspiration biopsy, it was a benign lymph node, and the patient has a history of PT2 and 1B papillary thyroid cancer with detectable plasma TG concentration. What do you think of this lesion here? So you have the trachea here, the carotid, the jugular. So this was a suspicious lymph node. You can describe this lesion as a hyperechoic tissue looking like thyroid with a round shape. And on needle aspiration biopsy, it is a metastatic lymph node of a classic papillary thyroid cancer, PT3B and 1A. So what do you think about this lymph node? So you can describe it as a suspicious lymph node with thyroid-like tissue appearance and peripheral vascularization. And at needle aspiration biopsy, it was a metastatic lymph node of a papillary thyroid cancer, PT2 and 1B. So what do you think about this lesion here? Just behind the carotid. So this was a very suspicious lesion in the thyroid bed. The patient has a history of papillary thyroid carcinoma N1B, and you can describe it as a hypoechoic lesion, with irregular borders and an ovoid shape. What do you think about this lesion here? So this was a suspicious lymph node with a hyperechoic tissue looking like thyroid, a round shape, some cystic areas here and here. And at needle aspiration biopsy, it was a metastatic lymph node of a papillary thyroid cancer. So what do you think about this lesion now? So once again, a suspicious lymph node with thyroid tissue-like appearance. Here cystic areas, maybe also here few cystic areas. And at fin needle aspiration biopsy, it was a metastatic lymph node of a papillary thyroid cancer. So now, what do you think about this lesion? So you can classify it as indeterminate lymph node because of the increased central vascularization. It was located in the left 3-4 level in a patient with a history of left diffuse sclerosing variant papillary thyroid cancer. So now, what do you think about this lymph node here and this lymph node here on the 2B mode and on the power Doppler mode? Okay, there is no trick. These were normal lymph nodes with the presence of a normal hyperechoic central hilum, central vascularization, normal central vascularization, sorry, a flat aspect, long axis to short axis ratio above 2, and without microcalcification or cystization. And this patient has a history of PT1B and 0 papillary thyroid cancer with undetectable TG plasma concentration. And what do you think about this thyroid bed here between the trachea and the carotid and jugular? Okay, so once again, a normal thyroid bed with the internalization of the carotid and jugular axis. And the patient has a history of papillary thyroid cancer, PT3A and 0, with detectable TG under a TSH simulation. And I really thank you for your attention.